Okay.
Hello and welcome to a special interview for The Wire. What is the true picture of the global spread of COVID-19 and how do the world's top epidemiologists view India's fight against the virus? Those are two critical issues I shall raise today with Professor of Theoretical Epidemiology at Oxford University, Sunetra Gupta. Professor Gupta, let's start with the global picture before we talk a little about India. As of this morning, Wednesday, the 3rd of June, there are 6.4 million cases globally, 382,000 deaths. However, 5 days ago, on the 29th of May, we had a sudden spike of 125,000 cases, which I believe is the biggest single day load in the last 5 months. It's also 35% above the average for the whole month of May. Does that suggest that we still have a worrying potential for cases to accelerate and for the situation to become perhaps considerably worse before it starts globally getting better?
Well, I think it depends on which region of the world you're looking at. But before I go on to talk about what it means, I'd like to say that looking at cases is not the right way to understand what's going on in this epidemic, because this infection is often carried asymptomatically by people. So um, the actual extent of spread is not evident in what are recorded as cases. So in different parts of the world, there are different ways of recording cases. So in some parts of the world, people are being tested to see if they carry virus in their throats. In some parts of the world, cases are mainly based on who's coming into hospital and whether they present with the symptoms of the disease. So the whole concept of trying or the whole idea that one can get a handle on what's happening by recording, by looking at numbers of cases is flawed, because not just because of the variety of ways in which they're recorded, but also the populations in which they're recorded, the levels, the effort that's made in testing different sectors of the population. They're all completely different everywhere. So the cases I wouldn't concern myself with. The
Can I
death,
interrupt at that point? You're therefore suggesting that actually we do not have a clear idea of the number of people that could be infected because different countries, different geographies record cases on a different parameter, and to total it up together is rather misleading. The total impact of this virus could be much bigger or possibly theoretically a lot less.
yes, it depends on what you mean by the impact. So it could have disseminated far more widely, and that has always been my suspicion, than is reflected in numbers of cases. Um, but yes, as I was going to say, the deaths now, that's a bit more of a concrete measure. Although there again, there are issues about whether people died with COVID or with the virus or of COVID, which is actually the disease. So whether they died with the SARS um, 2 coronavirus or whether they died of COVID, which is the disease that it causes. There are issues there, and then that would mean that in some cases the deaths are being inflated, and then in other cases, of course, there are deaths that are going unrecorded because they're occurring in parts of the country where they wouldn't be picked up.
You mentioned a moment ago that there could be a sizable number of asymptomatic people who are affected who we may not even know about. How much of a concern are they? How likely are they to infect others? If I recall correctly, in March there was a great fear that their capacity to infect was perhaps the same as someone who was symptomatic. Now there seems to be some measure of doubt about that. What's your position on this?
Well, I think that asymptomatic people are very likely to infect others, but not to the extent that a symptomatic person does just by, well, there's a sort of valley here, if you like, or a peak, where I think if you're symptomatic enough to be sneezing, you're probably the most infectious that you could be. Whereas if you're symptomatic enough to be lying isolated in your room, with or without the rules that tell you to, you're less likely to spread it. So there's a kind of optimum point in between where you'd be most symptomatic. So if you're completely asymptomatic, you're probably not shedding much virus. If you're seriously critically ill, you're probably removed from the system, but somewhere in between would be where you'd be most symptomatic.
Okay.
But that's not bad news.
I understand your point, but let me come back to the cases because, in a sense, that's what we have to go by. Now, when we had this peak on Friday, the 29th, of 125,000, I noticed that 60% of those came from just four countries: India, Russia, Brazil, and America. Is there a sense in which you can therefore consider those countries of special concern, or would that be a mistaken way of viewing them?
I think that is absolutely not how I view it at all. I think in Brazil, it's clear, and again, that's from the deaths, that the epidemic is starting to spread and hasn't quite reached its peak yet, or hopefully will do soon, but it's lagging behind, not surprisingly. It's in a different hemisphere, and it's in terms of the global dissemination, the virus got there much later probably than it did undoubtedly to India and most certainly in Europe, and then to America. So, there'll be a lag in when the epidemic actually gets to a country and takes off. And so the numbers of cases in Brazil, and more importantly, the deaths, reflect the more recent entry of the virus into the population and the fact that it's taking off now. In America, it's probably simply a matter of who they're testing, where, and I haven't really looked into that. Russia, I don't know.
Okay.
India, I'm hoping, is a case of where, again, just a matter of who's being tested and where.
I'll come to India in a moment's time, but let me stick with the global picture for a while. One of the other features that's becoming apparent is that as the rate of increase in Europe and America begins to diminish, the rate of increase is accelerating in South America and India. And these are parts of the world where the robustness of the healthcare system is questionable, to put it mildly. How much of a cause of concern is that? That it's now spreading to countries and accelerating within them where the capacity of their healthcare to handle it is very limited.
Well, I think I will confine my comments to Brazil for the moment. I think it's clear in Brazil that it is spreading. It has come in and is spreading and is causing a significant number of deaths. And yes, it's it's a complete tragedy that if it's done considerable damage in countries which were supposed to have the means to deal with the upsurge in deaths from this new epidemic. But that's obviously harder. Those conditions are very hard to meet in places that are under-resourced.
Now, as an
it's notable that in the UK, that which should have been resourced to meet this crisis, that it wasn't.
As an epidemiologist, do you have any sense when globally we will reach the peak? Or if that's difficult to predict, does that also mean we have no idea when this present wave of the pandemic will start to abate?
Well, I think it has started to abate in, for example, Europe. And I think in the Northern Hemisphere, it has abated. So we'll come to India in a minute. And it's picking up in South America, in Central America. And hopefully in the next 3 or 4 weeks, it will have passed through. The first wave, if you like, will have passed through. So by the end of July or so, hopefully, Brazil will also see the numbers of deaths diminishing to very low levels.
Now, internationally, with the exception of perhaps a couple of countries, the world chose to fight the virus with lockdowns. Do you have a sense of how successful these lockdowns have been?
Well, the problem with lockdown, for starters. So I think one has to first think about what is lockdown for. So what can lockdown achieve? Well, it's clear that lockdown can keep the virus out completely, and New Zealand is a case in point. If you come in early enough and you manage to isolate the cases, you could actually stamp out the disease, stamp out the virus. That's one thing lockdown can achieve. But that's not possible if the virus has already disseminated quite widely. And so the notion of using lockdown to stamp out the virus in Europe or India is, well, I won't say it's misguided. I'm just saying that is not something that could have been achieved by lockdown. So what else can lockdown achieve then? Lockdown can slow the rate at which new deaths accumulate. So that's one rationale for it. This means that what one is doing is delaying the costs of the virus, the epidemic, rather than getting rid of it altogether. And of course, that could be justified in the context of what healthcare facilities are available. So that's the sort of flattening the curve idea. And finally, one thing lockdown can do, and I believe that is why it was instituted, for example, in Italy in the first place, is to try and stop the virus from spreading outside of the area where it's located. And that was done in Italy, clearly, again, unsuccessfully. So the issue is, has lockdown helped? It's helped places like New Zealand keep it out. To what end, I do not know. I don't know. Are they intending to remain isolated forever? I mean, or are they waiting till the rest of the world is more or less immune so that they no longer have to suffer the risk, which is, again, unlikely? Are they waiting for a vaccine? I don't know. It seems to me a very short-term strategy to try and keep it out altogether if you want to belong to the global economy.
Let me bring up Sweden as an example. It was a country that didn't impose a lockdown, whereas its neighbors, Denmark, Norway, and Finland, did. Today, I believe Sweden has something like 443 COVID deaths per million of population, which is roughly 10 times worse than Norway, 7.5 times worse than Finland, 4 times worse than Denmark. Do you believe Sweden was right, or was it mistaken in imposing or not imposing a lockdown?
No, I believe Sweden was entirely right in not imposing a lockdown, but that comes from the consideration that is paramount here, which are the costs of lockdown itself. So, yes, indeed, lockdown can flatten the curve, and it can reduce, at least in the short term, the number of deaths. It's very unlikely to reduce the numbers of deaths in the long term. And it has an enormous cost, lockdown. And that is what seems to be missing from the debates about COVID.
But has Sweden avoided the cost? Because the country's central bank is now forecasting that Swedish GDP could diminish by something like 10%. Doesn't that suggest that Sweden has failed to contain debt compared to its neighbors, but it's also failed to contain damage on its economy? It may have lost out on both counts.
That's a very interesting question, but I don't know enough about why the Swedish economy would be suffering to answer that correctly. And one reason the Swedish economy might suffer is because it is part of a global economy which chose to enter, where many countries chose to enter into lockdown. So that's one possibility. The other possibility is that the Swedes, of course, did implement some form of social distancing, and the economy did slow down as a result. So you could ask the question, and that's a very valid question, even if you don't go into lockdown, if you do impose some form of, or not impose, if you adopt, if the population voluntarily adopts some form of slowdown, where does it leave them?
That's a very good question. But the logic behind the Swedish strategy was to permit the country to lead a life as normal as possible, at the same time as allowing herd immunity to build up. Now, a recent report in the London Times says that random antibody sampling in Stockholm suggests that only 7% of the state's population has been infected by the end of April, which I believe is way below the 50 or 60% considered necessary for herd immunity. So I have two questions there. Are you surprised? And secondly, does this suggest that maybe herd immunity takes a lot longer to build up than people had assumed?
Well, this is precisely the question that I've been working on. So first of all, herd immunity, what does that mean? So herd immunity simply means population levels of immunity. So obviously an individual becomes immune, and as soon as an individual becomes immune, they become unavailable for infection. And so what builds up in the natural course of an epidemic is immunity at a population level. Now, in order to eradicate an infection, you need to have a level of immunity that is dictated by the fundamental transmission potential of that particular pathogen. So, for example, if the bug infects, if one person who's infected with the pathogen typically infects around 2 people, you need 50% of the population to be immune for that pathogen to be eradicated. Okay. Now, we do not, we haven't eradicated anything, even through vaccination, because, in fact, the whole concept of using vaccination to eradicate relies on herd immunity. But as you know, we haven't eradicated any human disease other than smallpox through vaccination. So when people talk about herd immunity, they're clearly not talking about achieving the levels that allow COVID to be exterminated. What we're really talking about is a level of immunity in the population that causes the risk of infection to settle down to an equilibrium level, which is quite low. So that's my first point. So when people go on about herd immunity and needing 60, 70%, they're talking about the levels that would be needed in order for COVID to disappear altogether. Now that's a fantasy. That's very unlikely to happen, given our experience with other pathogens like COVID. So now we're talking about, can we let the pathogen sweep through so that we have enough of the population being resistant to the virus such that the risks, the individual risk of catching the virus is low enough that we can manage it, which is the case, for example, with influenza. Influenza, if we were all non-immune, we'd have a terrible situation with influenza, but we're not. Most of us have some degree of immunity to influenza against disease and death, if not infection. And many of us have immunity to infection, as a result of which the risk of influenza is low enough in the population that even though it still causes, 20 to 30,000 deaths in the UK alone, 650,000 annually, that we can manage it. We have the resources to keep it under control. We're not locking down because of influenza. So that's where we want COVID to get to. So that's the first point. Sorry, this is quite a long answer. So the level of immunity we want in the population is not such that COVID dies out. It's such that we can manage the risk of it. So then the question, what I was hoping is that these antibody studies would show that we had reached those levels where the risk was low enough that we could manage it. The antibody data, the tests, the data are actually not, they're all over the place. The numbers that are being thrown around depend on very much on the agenda of the people who wish to either prove that it is a very deadly disease, or those who wish to say it's not. And in fact, it is highly heterogeneous. There are pockets of certainly Sweden where there are at least 14, 15%, according to some of the numbers that are being thrown around. And then there are regions where they're very low. We've been conducting a similar study in Scotland, and we can see that in places like Glasgow, they're much higher than in the rest of the Scottish, the area. And we're looking at blood donors in Scotland in this instance. So basically, there's a lot of heterogeneity. We don't know what, in some areas, there are very high levels of infection, such as New York City. But the other point, final point, is that the antibody tests aren't perfect. And furthermore, that whether or not you have antibodies is not the only indication of whether you're resistant to the infection.
The key point there, particularly for an audience in India, and I'll come to India thereafter in a moment's time, is that you don't need herd immunity to develop to the point where the disease is eradicated because it can't actually then get transmitted to anyone else. What you need is, as you called it, an equilibrium level. Now, what sort of equilibrium level do you roughly think would work? Do we have any idea? Or is this something we have to wait to find out?
We do, because actually that equilibrium level depends on precisely how transmissible the disease actually is. And while there have been numbers thrown around between sort of 2 and 4, it could be even lower. So if it's around 2, we would want around, if it is 2, the very basic epidemiology tells you that 50% of the population being infected would cause the disease to be eradicated. So somewhere around 30 to 40% should be sufficient to keep it under control if it's around 2. If it's less than 2, it would be less than that. So
and if it's higher, then obviously...
If it's higher, so the numbers of sort of 60, 70 are coming from it being higher. So, for example, if it is around 3, what's called the R0, the transmissibility of the pathogen, if one person infects 3 people on average in a completely susceptible situation, then you need around 60, then you need exactly, theoretically, 66% of the population to be immune before the disease sort of dies out.
That's very clear. One more question before I come to India, but you'll see why I'm asking it. Yesterday, Public Health England released a report which clearly suggested that blacks and Asians in Britain seem to be more vulnerable than the white population. And if I read the report correctly, Bangladeshis in particular were said to be twice as vulnerable as white British people. Do you have any explanation for this difference in vulnerability?
Well, I think first, the difference in vulnerability is, first of all, the key to how we address the current crisis. And we know that the vulnerable sectors really certainly in Europe and certainly in the UK, most of the deaths have occurred in very old, very frail people. But then there are other people who are vulnerable who have what are known as comorbidities. So one reason I think the main reason I would wager that the main reason why we are seeing higher rates of death in these communities is because of their socioeconomic conditions that predispose them to possibly higher infection and also probably a bit to having the comorbidities, diabetes, obesity, and other things that predispose them to having worse outcomes upon infection. There are other genetic factors that people are looking into, and they may play a role. But my suspicion is that, we've seen the same pattern in New York, that socioeconomic status does come with it. Linked to it are the comorbidities that make you particularly vulnerable to this disease. And then, of course, there's the management of it. I mean, I'm sure in the UK, the management of disease cases among the Bangladeshis in the East End was of the highest standard. But the fact is that the frequency of those comorbidities is just higher in those populations.
Okay, let's take a break at that point, Professor Gupta. When I come back, I want to talk to you about India. And in particular, I want to put to you the statistics that the Indian government believe suggest that the virus is behaving differently in this country. In other words, India somehow has an advantage over the rest of the world, and ask whether you agree that those statistics lead to the same conclusion. But first, a quick break. Welcome back to a special interview for The Wire. My guest is Professor of Theoretical Epidemiology at Oxford University, Sunetra Gupta. Professor Gupta, let's now talk about India. India today has over 200,000 cases, but the government is adamant in insisting that community transmission has not begun. They say at times it's a matter of semantics. On other occasions, they say even if there is some sense of community transmission in cities which are called hotspots, clearly there are large parts of the country where the numbers infected are very low. So the government refuses to give the country a clear answer on this issue. What's your hunch? Can you have something like 207,000 cases, which I believe is the tally today, and still not have community transmission?
I'm not sure what is meant by community transmission. As I said, the picture that's emerging from these, albeit flawed, antibody tests and studies around the world is that there are settings in which it's spread, disseminated quite considerably, and other settings where it's not. So, London has had a huge wave. New York has had a huge wave. It appears from what I'm see that Mumbai has a serious problem. But the truth is, it's clear that in many countries that it is localized and hasn't necessarily disseminated to some of the other areas, particularly the less populated areas. I don't think it's because, as I said, the disease can be asymptomatic, or its symptoms can be easily confused with influenza. It's very difficult to know the extent of the spread of the disease without doing some form of antibody testing. Even if it doesn't give you the full picture, it gives you some sense of who has already had the virus. And it would be my sincere wish that such studies were carried out on a large scale in India.
Let's come at this point to the 3-4 statistics that the government of India almost every day proclaims at regular press conferences, which it suggests, A, that the disease is behaving differently in India, and B, that India seems to have some sort of advantage over other countries. And I'll take you through those one by one. To begin with, there is what the government calls the recovery rate. It's said to be 48% in India, but I noticed that Italy, with over 33,000 deaths, has a recovery rate of 68%, 20% better than India. Spain, with over 27,000 deaths, has a recovery rate of 69%. So clearly, you can have very good and high recovery rates, but also side by side, very large and disturbing numbers of deaths. So how much comfort can India take from a 48% recovery rate?
Okay, so this is where it's a very good question, because it allows me to touch upon the distinction between the risk of dying upon being ill and the risk of dying upon getting infected. And the two should not be confused. So one is what you might call the case fatality rate, and that is tied into the likelihood of recovery. So all the numbers that you're talking about have to do with the case fatality rate. So a disease case being one where the illness is manifest in whatever symptoms you choose to call COVID, and then whether it progresses to being severe, and then leading to whether it leads to death. Those are the things that are under consideration in talking about, do you recover from COVID? But the bigger question is, do you, upon becoming infected with COVID, get ill at all? And then if you get ill, do you die? So that is the number that is more crucial in thinking about what kind of public health policy to implement. So it's very, it's easy. So that number of what at a population level, who is going to die and what the numbers will be at the end, depends not just on the case fatality rate, but also on what proportion of the population is going to get ill at all. And this, I think, is possibly radically different for India, for sub-Saharan Africa, than it is in Italy and the UK.
Is that because of the age profile? In India's case, 90% of the population is under 60. It's a very youthful population. Is that one reason why the number that will actually fall ill or get infected would be lower in India than, say, Europe and America?
Absolutely. That is the critical reason. So the age structure of the population is the fundamental thing to take into consideration when thinking about what effect this virus will have on the total population of the country. However, so this is completely compatible with the idea that if you get ill, though, particularly severely ill, you are less likely to recover in that setting. But if that's confined to a smaller segment of the population, you still overall will not get the kind of effect or the numbers of deaths piling up as we did in Italy and the UK.
What you are saying echoes what epidemiologists in India like Jayaprakash Muliyil and T. Jacob John have been saying, that India's great strength is the youthful character age profile of its population. And what India should do is protect the elderly as well as those with known comorbidities, but let the young go out and work and get the economy working. Would you agree with that strategy, or would you say it's too much of a risk because the healthcare system in India may not be robust enough to protect the young when and if the young get infected?
No, I would agree with that strategy 100%, and I think that's what should have been implemented also in this country. I think that, and I say so because of the enormous costs of lockdown. So that it is the strategy we employ against many other infectious diseases, which are equally deadly, like influenza or TB. I mean, we have millions of people dying of these diseases, and we don't lock countries down because of the huge costs of lockdown. So something like coronavirus, which is clearly only affects a very clearly defined vulnerable sector, the way to deal with it without causing untold harm to people who are vulnerable to the effects of lockdown, is to shield the vulnerable people and let it disseminate it in the population, which, we should be in India, we would be as well equipped to deal with any unfortunate sort of cases of COVID and those who aren't supposed to get it, as we do with flu.
You began your answer by saying that, in fact, this strategy should have been adopted by the United Kingdom as well. Now,
Yes.
India, as of the 1st of June, that's Monday, there is a sense in which you could say the government is attempting to do this. We're now into no longer lockdowns, but what we call unlock one. And all activities have been permitted, except that there is a curfew of sorts between 9 at night and 5 in the morning. But hotels are still not allowed to function, metros are not allowed to function, but airline travel has started, railway travel has started, offices have started. So do you believe, given the fact that India is a poor country, where 300 to 400 million people, if they don't work, don't eat, and could end up starving and destitute, that this is clearly the right approach, and in fact it should have happened a lot earlier? That the scenes we saw on television of migrants trudging back would have been avoided if this had happened earlier.
Yes, I do. And that is why I'm sitting here talking to you. And that's why I got into this debate in the first place. I was terrified when these lockdowns started to come in earlier this year that this would be the case. And that's why I got into this debate. That is my primary reason for sitting here and talking to you. I find the fact that we have entered into these arrangements without considering the untold harm that this will do to the economically vulnerable to be really very difficult.
In other words, panic as a result of fear of COVID and perhaps an exaggeration of how badly it could impact us led us to ignore the horrible impact on economies and on poor people, and we seem to have perhaps made the wrong decision.
I think so. I think that what's also unfortunate is that, at least in this country, lockdown was sold as a sort of communitarian activity, and at some level, of course, it is. I mean, you stay in your homes, you enter into this kind of situation, really rather ridiculous situation of not seeing your own grandchildren. You stand 2 meters apart in a queue and wear masks. All of this is kind of a huge kind of social exercise that clearly requires the cooperation of a lot of people. And I do think the members of the British public should be congratulated on. And not just anywhere where lockdown has been implemented successfully, on showing that they are able to, as a community, do that, if that's the right thing to do. But the truth is that it may be communitarian on that one particular axis of, oh, okay, if we do this, the risk of infection will be temporarily lowered in the whole community. But if you consider at a global level, and indeed also within the UK, how that action affects the economically vulnerable, the dispossessed, the poor, the people who don't actually have homes in which to lock down, people who, when locked into homes, will suffer from all kinds of conditions like domestic abuse. But more importantly, of course, people who will be left without jobs, unable to feed their children, children not being able to go to school, when that might be their only sort of escape from a situation which is quite grim. When you take all of those things into account, it no longer appears to be such a communitarian activity.
That's very clear. We're coming to the end of this interview. Let me very quickly take you back to some of those statistics that I mentioned that the Indian government keeps quoting as sources of comfort, and ask whether you, as one of the world's renowned epidemiologists, believe that these are really reassuring facts or possibly meaningless ones. The second statistic is what the government calls the mortality or fatality rate. In India, it's said to be 2.82% compared to a global average of 6.13%. But I noticed that on Worldometers, there are over 100 countries that have actually fatality rates that are even lower than India's. And some of those are in the top 20. So how comforting is this fatality rate of 2.82?
Well, as you said, it's most of this will be contingent on the age structure of the population. So, of course, there are other countries. I mean, again, sub-Saharan Africa, South Africa enacted this in very stringent lockdown, and there too, it's a population where only, I think, 2% of the population is over 65. So it's not surprising that, given that many populations do not have a very large proportion of elderly people who are at risk of dying, that it should be very low. And I mean, that is indeed a cause for great optimism and a reason to immediately lift lockdown in all of these settings.
Low fatality, the country you mentioned, is a reflection of the age profile of the population. It's a very youthful population. They're less likely to get infected, and much more less likely to die if they do get infected, it's not necessarily a pat on the back to the government for handling it well.
Yeah, no, I don't think so. I don't think that India should have had to endure lockdown, and I don't think the migrant labourers should have been packed into trains without food and water. And I find it absolutely heartbreaking. Actually, that sounds like a rather casual word. It's beyond tragic that the most vulnerable, economically vulnerable, had to pay the price for this.
Let me put you a third statistic that the government frequently mentions, and it's what's called the doubling rate. India has gone up to 15 days. But I noticed that your country, the United Kingdom, and America have a doubling rate of 35 days. Italy, with a huge number of deaths, has 55 days. Spain has 56. And all of these are countries with large number of deaths. So how meaningful is a doubling rate?
Well, it depends on exactly. It's not. It's a way at the early stages of the epidemic of getting a handle on how quickly it's growing, provided you're measuring the right thing. So if you're looking at the doubling rate of deaths, that does give you some sense of how, or at least the rate at which it's disseminating within the vulnerable sectors of the population. Cases, as I said, there's so much variation in what would be reported depending on who's tested. It's not at all a useful measure. So I think what one should focus on are the numbers of deaths and, yeah, the rate at which that's doubling. That does give you some sense of how quickly it's growing within vulnerable sectors. But the most important statistic to focus on is who is dying. And it's clear that people under the age of 65, I think they are probably getting infected just as easily, but they're not dying. And I think that is the main thing on which to predicate any further public health strategy.
We're coming to the end of this interview, but on the basis of the statistics that I quoted you, the recovery rate, the mortality rate, the doubling rate, and also on the basis of certain statistics got from hospitals, where only something like 6.5% of Indian cases go to hospital, less than 3% need ICU care, and under 0.5% need ventilator support. On the basis of all of this, the health minister says that the virus is not that virulent in India. Do you think he's right in terms of the virulence, that maybe it's changed and it's a different strain? Or do you think, in fact, all of this is to do with what you mentioned, the age profile? It's a younger country, it will take it better. Which of the two do you think it is?
The second. I don't know of any evidence that, or indeed any biological reason why the virus should be milder or more attenuated in any respect in India.
My last question. At the end of the day, I suppose everything hinges on the level at which and the extent to which you're testing. Now, so far, per million, India is only doing 2,800 tests, whereas Spain has been doing 86,000 tests per million, Italy 65,000 per million. When asked, the government says we're testing strategically, which is why this number is sufficient. But for a population of 1.38 billion, do you think it's enough, or do you think it's woefully little?
Well, I think it depends on what you're testing for. If you're testing for who currently has the virus, I don't think that's terribly important, because that's important if you're going to implement contact tracing and isolation and that sort of thing, which I don't think is the right way forward in India. But what I would recommend highly is implementing these antibody tests, inadequate as they may be in some ways of giving you a sense of how far it's disseminated. But what I would do is what I'd like to see is large-scale studies using these antibody tests to see where it has got to. So, for example, if you do go to the Rann of Kutch and do some antibody testing and you can't find a single person with antibodies, then you will know that that area is still a sort of pocket that hasn't been reached by the virus, and then can direct efforts or make sure be prepared for a possible surge there, maybe next winter.
It's interesting you mentioned the run of Kutch, because that suggests to me you need to do these antibody serological tests in a very widespread manner. The Indian Council for Medical Research has announced that it is doing these, but it's only doing them in 69 out of India's 739 districts. That's less than 10%. I presume that's just far too little. It needs to be much wider and done literally nationwide.
Yes, I think that would be a very good idea to give us a clear picture of where it's spread, where it's still not spread to, and then use that to plan where to allocate resources for the next wave of this virus, which will, I think, come hopefully much diminished, because many of us hopefully will have been infected and have some immunity. But I think by identifying the areas where it hasn't reached at all, one could allocate resources or be prepared for something to happen next winter, where we have enough we're prepared enough to deal with the situation.
I was going to end at that point, but you mentioned the second wave, which you said will come. We don't know when the first wave will end. Do you have any idea when the second wave will come?
Well, I think that the first wave, maybe there won't be a wave because, as you say, the age structure is such that it's not going to, even though it's disseminating through certain areas, there won't be many deaths through which to perceive the wave. But, for example, it's clearly spread through certain urban centres and is likely on its way out, as we've seen, again, by looking at other settings in global settings. And overall, I think with this pandemic, it would have been advisable for us to have treated it as a global problem rather than as local problems. And so in India, we can learn from what's happened in other regions. So it's clearly spread through London and it's on its way out for the moment. No doubt that it will come back and there will be another surge probably in winter, but hopefully it will be much lower and more contained and will eventually settle into a pattern just like flu, where we know how to deal with it. It's part of our lives. That's what happens with many of these viruses. But at a global level, we can deal with this, but not by locking down and closing borders and trying to keep it out, but having a view whereby we accommodate this virus at a global level, as a global community.
That's interestingly and intriguingly put. We need to accommodate this virus. I would say we need to learn to live with this virus. It's not going away, but we don't have to live in fear and panic of it. Professor Gupta, thank you very much for the time you've made available and for speaking to me. Take care.
Thank you. It's been a pleasure.
To receive instant updates on all videos from The Wire, click the subscribe button and hit the bell icon. Pay to support independent journalism. Click the link in the description and choose the amount you want to pay.